presentation. Now, I would like to request our next speaker, Professor Khaled Mohsin, to give his presentation in the topic of atrial fibrillation and heart failure. Professor Khaled Mohsin is a professor of cardiology, Universal Medical College. He is also Joint Secretary of PSCI.
Thank
Professor
you.
Khaled, sir.
Thank you.
You are not visualized.
Yeah, can you see my slides?
Yes, sir.
Okay. Chairpersons, moderators, learned audience. First of all, I would like to thank the organizers of this 4th International Conference on Cardiac Intervention and Heart Failure Management, and for inviting me to participate in this conference as a speaker. We have been hearing a lot of very intriguing lectures on different aspects of heart failure, and my topic is a bit deviation. It's the arrhythmia and the heart failure. So it would have been better presented by an electrophysiologist, but I'll try to address this issue. We have already been hearing about the epidemiology of the heart failure worldwide, but the atrial fibrillation, the prevalence is about 1 to 1.5%, and it is rapidly increasing and expect to rise 2.5-fold by 2050. The very age-old study of Birmingham study has shown that heart failure, atrial fibrillation predicts higher mortality in both men and female. The odds ratio are more in against women, and though the incidence of heart atrial fibrillation is more in men, but the probability of strokes is more in female with atrial fibrillation. It is a major heart failure, as we have all heard. It is a major health problem all over the world, and it's a lot of people are affected, and about 550,000 new heart failure cases are added each year in Northern America. The survival rates, they decline steadily after the diagnosis of heart failure, and if it is combined with atrial fibrillation, the prognosis is much more grimmer. If the atrial fibrillation and heart failure occurs concurrently, it predicts worse outcome in terms of all-cause mortality, hospital readmission, heart failure readmission, stroke readmission. The hazard ratio are all increased, and the risk of atrial fibrillation, in the setting of heart failure, the risk is approximately 4 to 6-fold, and the rise of atrial fibrillation percentage, it is about 10% in NYHA class 1 to about 50% in NYHA class 4. There are numerous trials, very renowned trials have shown that the relationship of LV dysfunction and atrial fibrillation and its association with mortality and death, which steadily rises with the decline in LV ejection fraction. There are many studies which has been reported in the literature for over the years. They almost similar data. One interesting data has been shown by the US National Registry for Heart Failure, that the patients who develop atrial fibrillation as a new onset, they are older people, mostly male, and there is significant racial difference. The black Americans, they tend to develop more problems compared to the Asians and whites. This is a graphical representation of prevalence of atrial fibrillation in different subsets of heart failure, like heart failure with reduced ejection fraction, and also the heart failure with preserved ejection fraction are also not exempted. And they also all ranges of heart failure, they have the problems like the heart failure, death, stroke, TIA, they are all increased, but with a difference in because in the heart failure with reduced ejection fraction, they have when they develop atrial fibrillation, the aggravation of heart failure occurs, and the stroke is also high in heart failure with preserved ejection fraction as well. And there is this is a data from a Swedish study, and which is extrapolated in other countries as well. We all know that atrial fibrillation, there is a lot of atrial systole, there is ventricular rate dysregulation, the reservoir and the conduit function of is altered. There is a there is some inflammatory parameters. They also play a role, like IL-6 and tumor necrosis factor and the renin-angiotensin activation. And in patients with a lower ejection fraction, the increased atrial effective refractory period, and there is a slowing of impulse conduction at the area of the fibrosis. The atrial action potential is altered, and this all contributes to the arrhythmia generation. And there is a ultrastructural changes, like there is a increased calcium load and inhibition of the sarcoplasmic calcium ATPase pump, and the density of the T tubules. These are also observed by electron microscopic studies. And there is the potassium current is also altered, and the cytokines I have already mentioned. The inflammatory cytokines play a role: tumor necrosis factor, transformation growth factor, the PPR, the cytotoxic T cells. They all play a role in generation of the arrhythmia. And this picture summarizes the pathological changes, and they lead to the ventricular rate increase, the increase in cardiomyopathy, mechanical stress, ventricular dilatation, cardiac fibrosis, inflammation. All the mischievous things occurs in the heart. And as I have mentioned, the role of inflammation mediated by renin-angiotensin system, interleukin-6, tumor necrosis factor, all the molecular mischievous agents, they play a role. The heart failure with preserved ejection fraction is not exempted from atrial fibrillation, and the prevalence is about 20 to 40%. And in course of the disease, about 2/3 of the patient develop atrial fibrillation, and they fare badly compared to the patient with reduced ejection fraction. Their exercise capacity reduces, the biomarkers increase, the left atrial enlargement occurs, and in the right atrium there are also right side of the heart there is elevated filling pressure. Then the deceleration time changes, the pulmonary wedge pressure increases, they lead to right-sided heart failure as well. And we all know that the untreated atrial fibrillation can lead to arrhythmia-induced cardiomyopathy. And we all know that if there is the atrial fibrillation, the cardiac output reduces about 25%, and this cardiomyopathy is potentially reversible, and so every attempt should be made for early diagnosis and reversal to sinus rhythm by different therapeutic means. Bleeding is an important risk of atrial fibrillation in the background of heart failure. Heart failure itself is a inflammatory and hypercoagulable state. There is a platelet dysfunction, endothelial dysfunction that both predispose to thrombosis, and risk of stroke is about in the heart failure patient is about 18 per 1,000 in the first year of diagnosis, and rising up to 47.
Only 1 minute more.
Yeah, and there is a 1,000. It increases steadily. The LS stasis, they predispose to heart failure. We all know the CHADVA score, the importance of anticoagulation. Nowadays, the NOAC is the preferred anticoagulation agent, except for the prosthetic heart valve and severe mitral stenosis. These are the recommendations we all know. And the different trials have proved the efficacy and safety of NOAC, like the dabigatran has Raleigh trial, Rocket has proved the efficacy of rivaroxaban, Aristotle apixaban, and Engage is endoxaban. These are all proved the efficacy. And LA appendage occlusion, it is a very attractive option in a patient where there is a high risk of thromboembolism, but the risk of bleeding is also high. The rate and rhythm control is a contentious issue in atrial fibrillation, but the rate control is of more importance. Some studies have proven the benefit of rhythm control as well, but rhythm control is difficult to sustain.
Sir, so time's up, so please wrapping up your lecture.
Yeah, so the rate should be 80 to 115 per minute, and the drugs, beta blocker, digoxin, and for the rhythm control, I think AV nodal ablation and pacing is also important. These are the summary, and the last we come to the take-home messages. The atrial fibrillation and heart failure can exacerbate one another. We should not forget about the anticoagulation standard heart failure therapy. Lifestyle modification should be considered as a first-line therapy. As the medical therapy has limited success, rhythm control by catheter ablation should be the modality of choice for restoration of sinus rhythm. Thank you very much for your patient hearing.
Thank you, sir, for your excellent